Gary, I just can't help asking, following Helen's speech, it's a bit unfair because Helen's not here to defend it, is the NHS in England has gone through almost constant reform for years. It never stops. What's the point in all this discussion about change when people in the service are completely fatigued by it?
Yeah, so I think you're right. There's many structural changes, and people have written about that. But the reality is that services do improve, outcomes get better, and I could have showed you, many areas where outcomes are improving and services are getting better despite the environment we're working in. I think it goes back to a point made by a couple of the other speakers, that if you're working the service, you've got to take a long-term view, and most people kind of overestimate what they can achieve in the short term and underestimate what they can achieve in the long term. And it's about being clear about where you're trying to get to with what you're trying to do with patients and taking opportunities when they come. And certainly that's been my experience. And I think many clinicians and health professionals understand that.
So just a question on your presentation. Why did it take a network to do those different areas of service improvement?
Okay, so the big problem in most health systems is many healthcare practitioners are isolated and unaware of how care is changing in similar services and are benchmarking themselves against what they and their team were providing before. In many areas, there are not good national data where you can have objective data to compare yourself to. But even if there are, a lot of work shows the way to drive change, the biggest way to drive change is through peer-to-peer, you can call it challenge or exchanging experience. I mean, I can change the views of another stroke physician. It gets much more difficult for me to change the views of a surgeon, even though I'm a clinician. I need another surgeon to do that. So not having networks means you get isolated pockets, and I think we've all seen it. A lot of the, when we have a major scandal about a hospital, you look back at it and it's been very isolated. The clinicians are not connected to what's happening elsewhere, and nor are the managers. And I think there's been many other exposition as to why partnership working is key if you're going to get effective change in a very complex ecosystem.
But Lisa, one of the features of when there's been crises in hospital systems, both here and in the UK, has been a disconnect from patients and communities. What have we learnt from Aboriginal community-controlled organisations that has yet to be adapted to non-Indigenous services, do you believe?
Apart from everything? No, don't say that lightly.
And it's a conversation we'll start to have tomorrow as well, by the way.
Indeed. The reality is that when you do connect with people and when you do include people in the conversations and include people in the structure and the decision-making and the spending and the requirements, you end up with a whole different kind of service. People know what they want. And it's only been recent years where we've looked at, consumer involvement in our boards and in how it is we structure our organisations. For Aboriginal and Torres Strait Islander people, they've certainly known for a very, very long time what's needed. And still today, a lot of that advice and that request is being ignored. We know that growing more workers into hospital systems at all levels, not just as the people that open the doors or deliver the meals, but people who are on the executive, senior clinicians, other medical staff, etc. That makes a whole world of difference of how people feel like they're included, how they belong, and many more people then start therefore contributing to the system in a positive way. It makes it better for us all.
Mike Farrell, one of the wicked problems internationally, but also here, are mental health issues, drug and alcohol problems, actually getting change on the ground. Consumer engagement, you could argue, in mental health in Australia has probably been, next to Aboriginal health, the best, yet it's still a complete mess. How do we tackle this within the framework of alliances, collaborations, partnerships? Is it just more slogans? Or is it getting to the heart? What gets us to the heart of what really matters about change? Are we just creating more structures and bureaucracies with alliances like this, or actually are we creating solutions?
I think it is much more than simply slogans when it comes to mental health and some of these what would be called marginal areas, because it's very important we put them at the very centre. And it's actually by putting them at the very centre of healthcare that we actually, it's the same as we've been talking about closing the gap. It's only by bringing these marginal issues right into the centre, and that involves change. And I actually think that one of the things that we need to understand in this system is the system is constantly changing anyway, and the problem we have is in certain ways shaping the change in the direction we want rather than being passively changed, and I think that's where we get some of the tension.
Bruce Neal, when you were listening to Les Levin's presentation about accelerated approval, getting people who are users at the early stage, regulators at the early stage, doesn't really sound like the pace of randomized clinical trials, which is your business. I mean, that's glacial. So are we talking about do we need new research methodology to adapt new technologies which have promise?
So I think we have pretty good technologies, but I think again we have significant problems in terms of the different parts of the system talking to each other and understanding each other. So we have, for example, in the clinical trial setting, a clinical research industry which is very used to doing things in a particular way and which actually makes a lot of money about doing things in a particular way. Now, if you take your projects or your ideas to that industry, they will come back with a very standard response which will make them a lot of money along the way in terms of delivering the output. Now, interestingly, if you go and talk to regulators like the FDA, they're way more interested in hearing about novel ways of doing things, ways of saving money, ways of short-circuiting clinical trials than you would ever hear about from the clinical research organisation industry. And I think that, I was sort of...
And as scientifically valid?
Sorry?
And as scientifically valid?
Yes, absolutely. I mean, a lot of the money we spend doing clinical research is spent around trivia, frankly. I mean, you could do very simple, very big trials and get at least as good science out of them. But I was reflecting on what Martin was saying, which was, it's all about leadership. And I'm not sure. I think so much of what we do is all about the money. And sometimes the leadership controls the money and constrains what the business outcomes are and what the business gets to say about the system and how the system operates. But all too often, I think that actually the leadership ends up following the money. So the business, our sort of neoliberal way of doing things in much of the developed world drives the way that we're doing things and often doesn't deliver us the best outcomes that we could possibly get. And I think that's true probably less so in the countries of most of the speakers that we've been hearing from, where we have pretty sophisticated systems, people, laws, regulations. But for the vast majority of the world that live in very low-income settings where we don't have those same sorts of systems and governance, I think money determines their likelihood of getting sick. It determines what treatments they're likely to get, and very often neither of those are actually aligned to the best outcomes for patients or for the societies as a whole.
And do you think that applies to disadvantaged groups in Australia?
Sorry, say that again?
Do you think that applies to disadvantaged groups within Australia?
So my other area of interest is food. As you're aware, and food policy in this country is sort of non-existent. I mean, we don't get mass poisonings, but almost every chronic disease in this country is driven by decades of consumption of too much salt, fat, sugar, plus, of course, excess alcohol, tobacco. We have pretty good laws around tobacco. We have some laws around alcohol, but we have nothing really around food. And that underpins more ill health in the country than anything else. And it's a big part of why disadvantaged communities do so much worse than better off communities as well.
So Les, is there a role for accelerated health technology assessment of things like sugar tax, fat tax, alcohol volumetric tax, rather than just new gizmos from your incubators in Toronto?
I don't think there's a standard way of evaluating anything. If I can just go back, and sorry, you asked the wrong guy, because, I heard a great quote the other day. Never think inside the box, never think outside the box, throw the box out of the window. I think that every technology has its own way of evaluating it. It has, our scientific collaboration has some of the really very, very bright minds, but they've all been hand-selected because none of them are happy with what's going on in clinical trials for health technology. And let me just explain that. The regulator is, no matter what they say, but what they want is evidence that the technology is safe and it does what the manufacturer claims that it does. For that, you need what's called an explanatory clinical trial, standard randomized controlled trial. The payer, on the other hand, wants to know, how does this technology perform in real time, and how does it compare with what we're already paying for? That's called a pragmatic trial. And we're moving towards a trajectory from explanatory to pragmatic through what's called an adaptive trial design. And I'm sorry to drown you in methodology, but it's using a Bayesian approach. And you're absolutely right. The FDA loves Bayesian approaches. They've given it the nod. We will be taking this to our Payers Advisory Committee to ask if they will accept this as evidence. It allows you to cut corners and address some pretty complex issues in terms of the evaluation of these technologies. So you can do this in one single study, and in fact, you can push it back to the pivotal, to the proof of concept study, and you can still take the data from that study and incorporate it into a pivotal trial in an explanatory, moving on to pragmatic in one fell swoop. Now, if they do this, I'll think that is absolutely brilliant, because that is addressing, I think, some of the complexities and the requirements. I'm dealing with a company in Boston at the moment who are on their seventh proof of concept study for an invasive cardiac device. Seventh. Well, this must be taking them like 20 years or something. And that's not the bad news. The bad news is that they're going to pass that cost, the cost of those multiple studies, are going to be passed on to you and to me.
So I understand that, and hard though it is, and a very valuable contribution. But if you think of social policy as technology, does what you've learned apply to social policy? So, Elizabeth, it's hard probably for Elizabeth to talk about this because she's currently a public servant and so on, but I will ask her anyway. But, if you want to introduce a sugar tax, are there things that you've learned, for example, that could accelerate the testing of that in any way? If you're talking about implementing a sugar policy rather than a new stent or catheter?
I just think it multiplies the level of complexity of what you're looking at. I think to do a clinical trial on everything that comes your way would be ridiculous. There's certain things where you can extrapolate from small data sets, and you can build it up into prospective data collection through big data collection. And in fact, if you look at it's not exactly answering your question, because I need to have a specific example. If it's a specific test, then you still have to validate the use of that test against whatever else you're doing at the moment to find out whether it's accurate and to find out whether it's cost effective. And to do that, you still have to do some kind of evaluation. The FDA is moving increasingly towards early conditional adoption through their NEST program, which we'll know much more about in 2 years' time. In fact, we're meeting with them on the 14th of December. We'll know much more about the NEST program, but they're trying to move into a combination of regulatory control and and addressing the payers' needs. But I'm going to answer your question because I need a specific example.
Okay, well,
I mean, just a quick comment. I mean, you can evaluate social interventions and social policy. And I think one of the things we're realising is the importance of doing that in an integrated system. And NICE is now extending its remit into social policy. I think there's an interesting challenge to the university sector to develop and increase the numbers of people who are capable of doing those evaluations. And so one of the things you run up against is you find whole areas which are really important in policy terms and in health need, and you don't have the researchers. We've got that in geriatrics, in multimorbidity, and in social policy, certainly in the UK, and I suspect that may be true in other countries.
Elizabeth?
Yes, I think that's one of our challenges, and if I reflect on what we're doing in New South Wales, one of the Premier's priorities was a reduction, is a reduction in childhood obesity over the next 10 years.
Yet at a national level, they're not willing to pull the levers that are going to make a difference to that. Unhealthy food advertising, sugar taxes, fat taxes, and so on.
No, and I think sometimes policy and politics is the art of the pragmatic. And we have had conversations at RMAC, and we've had discussions within the state as to what's possible for us to influence at a state level and what could be done at a national level. But the aligning of the planets for governments to actually agree on a way forward is always challenging.
So my question,
given the federated model.
So given the context today of this room, what, if anything, can broad alliances such as this do to make these policy changes easier or easier to understand, or the decision making easier?
I think it's a significant value add for our work in this space. And as Martin referred to, we're not the custodians of all the knowledge at a single point of leadership in the ministry, and our approach to the obesity strategy has been extraordinarily inclusive and engaged partners in the universities to seek out the best practice evidence, and engaged also with private companies and other government agencies also, in that it is a whole of government approach. It needs to be strongly founded on evidence, and that's what I'm extraordinarily proud of, the strategies we've developed around obesity. And it's a lot more defensible, I believe, in having the conversation then with the politicians and the community, that there is a strong evidence base for how we're moving this one forward. But it's not without its challenges, because some of the recommendations, or what we identify as bold decisions, do get left on the shelf.
Bruce, and then I'm going to come to Mark.
So I mean, I've had the good fortune to be part of that advisory committee for that Premier's priority, and I think it's been commendable that it's been put there as a priority. It's been recognised as being very hard, and it has had a truly sort of multidisciplinary look at it. But as you say, I mean, the primary recommendations around tax sugar, put marketing restrictions on advertising to children, these are things that are just politically impossible. And they're the things that actually are for which there's probably the best evidence and which are likely to be most effective. So I think we need innovation, as you were sort of alluding to, in this space, at least as much as we need innovation actually in the clinical setting, because in the clinical setting, we're talking about sort of tweaking treatments that are going to give us pretty small incremental changes. At the moment, we're doing almost nothing in food policy. And if we could get a 10% reduction in the average consumption of sodium around the world, or in Australia, we could get massive reductions. I mean, millions of lives saved every year around the world. And we would have to spend almost no money on it compared to what we would have to do in the clinical setting. So the opportunity is enormous because almost nothing is being done. But it requires innovation to enable us to figure out how to do it. At the moment, it's the purview purely of the industry.
So, Martin, I'll come to say, Martin, I mean, the mantra here is, well, first of all, I'll ask you one question, then I'll come to another one. One is, imagine you were still sitting at a national level thinking about this. You hear of these academic health science centres, you were part of that policy to encourage organisations such as this. How would you know they're going to be successful in a healthcare setting from your self-interest as a senior health bureaucrat?
How would I...
What's the measure of success? What's the metric? Because Gary referred to that as well. What's the metric?
Look, this...
Because the transaction costs are huge.
They are. Look, this is, I think, one of those really, really difficult, almost intractable issues. This whole notion around food and reduction of salt, sugars and a range of things has been discussed at more forums than I care to think of around the world. There's been very few who've actually made much difference. Even the WHO forum, the World Health Assembly forums every year, you have everyone coming together with all good intent. However, you can only get so far because of, I suppose, it is interest. It is other interests that do come to play. So how do we know what success looks like? I think, not that I believe sugar and salt and that food issue is the same as tobacco, but it is a policy initiative that is successful, but it's only successful because it's been going for 40 years and has about 15 different elements to it.
So my question, I actually have moved on a little bit from that. So my question, though, I'll ask it in a slightly different way, well, not the same way. Forget about sugar tax for a moment. Just talk about the work of a broad alliance like this, local health districts, universities, in theory consumers. What's the metric for success?
Well, you start to see a change in obesity rates. You start to see changes in the indicators that you would be looking at in that particular space.
Michael, do you agree?
Well,
it's very tempting to process things. We all got together, we had a nice time.
One of the indicators would be to set a target, first of all, because often governments are very reluctant to set targets because they're then locked into those targets. So the only other way, I think, that is a bit innovative at the moment has been some of the big modelling exercises have actually costed out the range of options in a way that's quite academically rigorous, and they're beginning to shape high-level policy decision-making in a way that's quite compelling. One of the interesting examples on alcohol is when you look at all of the screening and brief intervention and all of those types of fairly costly primary care interventions, a simple change in tax would achieve 3 times the life savings that any of the other interventions would. But again, we're back into the same terrain of what's acceptable and that.
Les, you wanted to make a comment earlier?
Yeah, sorry, I didn't get your... I think my ears are still popping from a 20-hour flight, so I didn't quite hear your question. Social policy doesn't require, in my opinion, and I'm going to take on some of my colleagues here, does not necessarily require the same level of evidence as technology or drugs, etc. I think for a lot of social policy, my experience...
It could cause more harm.
Sorry?
It could cause more harm.
My experience is that when you're looking at the policy decision, one approach would be to model it and to look at the downstream effects of your social policy decision. And I think you can do that in a fairly robust way. And there are different kinds of ways in which you can model it. I'm not sure that a clinical, if you're trying to put this squeeze it into the same box, the same sandbox or the same. I'll throw my box out the window. But if you put it into the same kind of context as a technology, I think you're going to get yourself in trouble. Because I think the requirements for social policy are somewhat different. If it causes harm, then you shouldn't be invoking or entertaining social policy in the first place. The assumption on social policy is that you're going to do good. The question is how best to do it and whether what you do is going to have its desired downstream effects and consequences.
I think we've now just embarked on a 3-hour conversation, but we won't have it. Can I just comment on metrics? I think this is really important. One of the things we've learned with in the research ecosystem is having good measures of research quality and more recently impact. And when we were looking at putting incentives in place to increase research activity in hospitals in England. When we started the research networks, we had no measures of activity. And it was really important just to measure it and to put it in league tables. And then you don't necessarily have a target. You're just saying, this is what we want to see more of. Because I agree, targets are very problematic in health services for a number of reasons. And then at the clinical end, you've got, we reduce stillbirths, we reduce stroke. So the question is, what do you measure in the middle that sort of takes that research that gets you to that bit? Because what we're talking about is not captured by either of those very easily, because the lags are too long. And I think there is much that can be done. We need to start to think about how do you measure, which organisations are good at taking up innovation. We don't have a good system for that at the moment in the UK. We are developing it. It's just for drugs at the moment, but it can be broadened. Because I think what you're getting at, I agree, is you just say, oh, well, that looks like a nice structure, people are together, it'll work. But you've got to have something more substantive than that to measure it.
So, Elizabeth, and just finally, coming back to full circle, we started off with a squeaky wheel. Nobody makes the wheel more squeaky than clinicians or doctors. Have we failed in serious reform because that's the squeaky wheel we listen to, and we go around with this mantra that we can only change with clinical leadership, it's got to be clinician-led? It's not worked. This is called a career-ending question.
That's why I'm smiling, Riley, and going to choose my words very carefully. Look, I think sometimes it's at the heart of what Martin says, and it came up in another presentation. Self-interest is unfortunately paramount, and the self-interest doesn't stem purely from financial, though on some cases it does. However, the self-interest stems too from the competitiveness for resources, that everybody wants to look after their own patch and they're quite protectionist of what's going on, and sometimes couched under the interests that I have to do everything I can for my patient, and I'm not fulfilling my duties of care if I don't actually order every test possible and explore every avenue and do all these complicated things that are necessary. And I think it's at part due to the training of individual care rather than an understanding of system operation. Because if you even look at emergency department targets, the 4-hour rule for right or for wrong, encouraging doctors to discharge patients who are ready to go so we can manage the pipeline of patients coming in, doesn't sit well, because I'd really rather they wait for another night, or their family can't pick them up till the next afternoon and will wait and go through a discharge process, which is really, really challenging. However, I think when we do manage to engage successfully in partnerships of setting that understanding of what we're collectively trying to achieve, the results can be outstanding. So I'm an eternal optimist.
I just want to add something there, because
you've got to deal with clinicians frontline, unlike a Secretary of Department of Health where you don't.
I can say a lot of things now, but self-interest is not about doctors. That's one element.
Of course it's not, but it largely is in the healthcare system.
Oh, no, I disagree. That's one element of it. You've got the device industry, you've got the pharma industry, you've got the 73 other different craft group industries that come along. You've got the consumer industry as opposed to consumers of healthcare. There are a range of different groups out there who have self-interest. And it's about how do we actually deal with that issue for the greater good of our health system. So I think they're the real challenges that we've got.
And briefly, Lisa, you wanted to say something?
Look, I do. I disagree that things are politically impossible. I truly believe in the power of the possible. I truly believe that we, as a group that's called today Maradulu Budjari Gummul, have got enormous power. We have got people in this group that belong to all parts of the world here, all parts of the disciplines, all part of the community that has a dream, we have a vision, we've got the skills, and quite frankly, if we can't nut out how it is we can manoeuvre our way through the politics to get something as daggy as sugar dealt with, then, you know, we don't need more innovation. Do we know what we need to do, people? Yes, that's the thing. We do know what we need to do. It's just a matter of saying, let's take a deep breath, get together and deal with it.
Glad I gave you the last word, Lisa.